Hi, my name is Eva Sevick. I'm the Kinder Distinguished Chair of Cardiovascular Research at the University of Texas Health Science Center, where I direct the Center for Molecular Imaging. Today I'm going to talk to you about imaging lymphatic function and dysfunction in human subjects. And I'll show you how we can actually use the imaging to monitor treatment and show how treatment affects lymphatic function and architecture. My disclosures are as follows. You'll be seeing human studies of near-infrared fluorescence that are conducted under IRB approvals using an off-label administration of ICG, or indocyanine green, or IC cardio green. These human studies were funded by the Longaberger Foundation through the American Cancer Society, the National Institutes of Health, the Cancer Prevention and Research Institute of Texas, and Tactile Medical Systems. I've also have financial interests in that I speak for Tactile Medical and lymphedema seminars. I'm a consultant to Sorrento Therapeutics on the lymphatics, and there are royalty interests in the imaging technology that I'm going to be describing today. This is the unidirectional lymphatic vasculature, and you're watching this video, so you're interested in it. Let's make certain that we're all on the same page. The lymphatic system, the way that you enter into the lymphatic system is through the initial lymphatics that are located right underneath the epidermis. They also line all the organs, the internal organs of the body. In this initial lymphatics, the lymph endothelial cells are specialized. They don't have any basement membrane. They open and close and allow excess fluid, immune cells, and waste products, macromolecules, into the lymphatics. Once in the lymphatics, these entities become lymph, and it's moved through the collecting vessels, through the conducting vessels that consist of lymphangions. These are segments of lymph vessels that actually look like hearts or lymph hearts. They're bounded by valves and have smooth muscle cells that pump in concert so that lymph is moved oftentimes against gravity through the thoracic duct. Along the way, that lymph transits through lymph nodes where immune surveillance occurs. Eventually, that lymph, after it transits against gravity up through the thoracic duct, empties into the supraclavicular vein, where all that material, that waste products, these immune cells, are returned to the blood system so that those waste products are metabolized by the liver. The immune cells go out and fight infection, and the fluid is restored to the vascular system so that we have fluid homeostatic. There are conventional means of imaging the lymphatics. One that you may have heard of is lymphoscintigraphy. In that case, what one does is one injects right underneath the skin into an intradermal injection, radiocolloid that's taken up by these initial lymphatics. And after several minutes of waiting around, one puts the patient underneath a gamma camera and counts the radioactive decay. And this decay is then formed into an image called a lymphoscintigram. And you see in this image the injection sites at the webs of the feet, or the webs of the toes of the feet, or in the hands. And there's a grainy picture that demarks lymphatic vessels. In the United States, we don't do an awful lot of lymphoscintigraphy. We also do lymphangiography. Lymphangiography consists of either cannulating a lymph vessel or under ultrasound guidance, injecting into a lymph node. And what happens is that contrast media goes through the lymphatics, and it shows this beautiful picture that you can get on MR or radiography or CT or X-ray. The problem with this is that this contrast agent, well, actually an advantage of it is this contrast agent in the instance of a leak can plug that leak. Well, the problem is that it's not necessarily a conventional imaging modality for monitoring lymphatics. These are processes and procedures that are performed by radiologists and interventional radiologists. We've decided to work for developing a point-of-care imaging that's based upon near-infrared light. It's light, it's non-radioactive, and so it's really simple to use. We're using indocyanine green that's used in studies for hepatic liver function. And what we do is we inject a trace amount right underneath the skin. That dye actually goes right into the lymphatics, And that dye tends to it actually has a fluorescent property. What we do is we illuminate the tissues with dim near-infrared light. That light penetrates into tissues. It excites the ICG that's located in the lymphatic vessels, and that causes fluorescence. That fluorescence propagates to the tissue surface, and we have a camera system that we've developed so that we can collect that fluorescence, and we can record it real quickly so we can get rapid images of the fluorescence, or this indocyanin green that's in the lymphatic vessels. Now, the secret to our technology, the secret sauce, is that we've actually adapted the night goggle technology from the first Gulf War. If you might remember, Iraq invaded Kuwait in the evening hours, and all those maneuvers were recorded using these night goggle technology goggles that the soldiers wore. What we did is, after the first Gulf War, we contacted the Army vendors, and they sent us these, and we took them apart and put them, adapted them onto these camera systems so that we can very sensitively image through several centimeters of tissue. And what you see here is this movie of lymphatic function in the lower legs of a person. And what you see is those lymphangions pumping that ICG-laden lymph from the feet all the way up into the groin area. So these are the things that you can see using this military technology adapted to medical imaging. So why is this so sensitive? Well, it's because of that military technology. Usually in imaging, we really want to have a high contrast. That is, you want to see the lymph vessel and discriminate it from the background. So that means you have to have a high contrast. And you want to have a high signal-to-noise ratio. You don't want to have a noisy image. So the best imaging technology is basically up with high signal-to-noise and high contrast. And unfortunately, without that intensifier, without that military technology, your signal to noise and your contrast is actually quite low, actually too low for you to be able to see and distinguish things from medical imaging. So we use this technology, and we develop our camera systems using phantoms that we've developed with NIST so that we can certify the performance of our systems. And that seems to be the reason why we have this differential performance. This is how you do it. You inject. This is a patient that has an injection of 1/10 of a cc of indocyanin green, about 2 to 25 micrograms of this dye. This is a trace amount. And you see that the dye is readily taken up by the lymphatics. The camera is so sensitive that in order to actually see the lymph vessels, we cover that injection site with a Band-Aid. And later on through this presentation, you'll see there's little black squares. That's like black electrical tape, because that's the only thing that we could find to stop the light from oversaturating the camera. Now, the interesting thing is that you have to do an intradermal injection. So you have to do a MAN-2 injection and have that wheal that's formed. If you go a little bit too deep, okay, you're not going to get access into the lymphatics, and so you won't see these images. So again, we place the dye right into these initial lymphatics, and you can do this anywhere in your body. It's taken up by the collecting and conducting vessels and pumped, oftentimes against gravity, through the lymph node, goes into the subclavian vein. There, that trace amount of indocyanin green is basically cleared through the blood system. So you really only see the vessels in the lymphatic vasculature. This is an image that's, hopefully you can see the motion in the arm. These images are sped up about 3 times, and there you'll note these black pieces of tape that cover the injection site so that you can see these beautiful pictures of lymphatic function. Well, it turns out that pulsing and that movement of lymph is due to those lymphangions, which are essential to the transport of lymph. It's essential for qi, that's the movement of this fluid through your body. And this is a video of a lymphedema subject with an injection in the heel. And you see the deep lymphatic vessels and the more superficial lymphatic vessels that are pumping. We can actually follow these lymphangions from the intensity as a function of time. And you see that the intensity goes up as the ICG enters into a lymphangion. Then that lymphangion squeezes it, and you see that the intensity goes back down, and you see this repetitious process. In the adjacent lymphangion upstream, you see when that lower lymphangion empties, the upper lymphangion fills up. These are characteristic waveforms that differ for everybody. It's not these waveforms, and this contractile activity is not necessarily related to breathing or to heart rate. When a person is perfectly still, you'll still have this, so it's not muscle contraction. We do know that these lymphatic rates are dependent upon position, and they're incredibly sensitive to the pro-inflammatory state of your regional tissues. We see that this ICG will move through all the draining lymph node beds, whether in the groin, in the elbow, in the axilla, in the thigh, and everybody has lymph nodes in different locations. So this is a way to actually probe where your lymph nodes are. And again, we can do this non-invasively, so you don't have to open a person up. These lymph nodes are taken out for staging, and as you know, that what oftentimes results is lymphedema. And in the normal arm, you have straight lymphatic vessels that conduct lymph to the axillary lymph nodes. But in the earliest stages of lymphedema, what you see is that we have these tortuous vessels, and we have this very fine, lacy lymphatic vasculature that's close to the surface. What we think is happening is that in the onset of lymphedema, before any swelling actually occurs, we think that these lymphangions that we have are weakening because of this pro-inflammatory state. And these lymphangions, when they pump, they create a pressure that moves lymph forward, that's from distal to proximal, and it creates a back pressure that sucks lymph from these initial lymphatic capillaries. When this pump is actually weak, what happens is we don't generate sufficient pressures to propel lymph forward or to suck lymph from these initial lymphatic capillaries. And so the initial signs that we see when patients that develop lymphedema, they get this dermal backflow. It can be this beautiful, lacy, lymphatic vessel that actually occurs right underneath the tissue. So an injection in the wrist will show these beautiful structures upwards closer to the elbow. So what we see is that as disease or this condition progresses, we see a movement from straight lymphatic vessels that pump to this dermal backflow where these lymphangions are becoming deficient, so we get even more dermal backflow up to the point where we don't have the vessels transporting lymph any further. What we have is this ICG-laden lymph that's all within the tissues, and it's extravascular. And that's the tough time. That's very difficult for lymph to move extravascularly. That's why we have lymph vessels, so that we can move that lymph effectively through the vessels. The therapists who we've collaborated with have actually used the technology to help them direct manual lymphatic drainage. So what we'll do is we'll use Bluetooth technology, and we'll pipe the images onto a plasma screen in the clinic wall, and they'll watch that plasma screen, and they'll perform their therapy by directing their fluid, the lymph fluid, to functional lymph vessels. And what we'll see is recruitment of new vessels. We'll see filling of vessels that were not previously functional. And you see that the therapists actually use the image to actually find these draining lymph nodes and lymph vessels and lymphangions, and trying to coax them to actually pump and move fluid. In cases where patients have advanced disease, where most of the green-laden lymph is located extravascular, we've actually been able to show that the advanced pneumatic compression garments, such as the tactile flexi-touch, actually can be used to move very effectively this extravascular lymph. This is an image before treatment, where you see the dye that's been injected in the hand has gone all the way up to the elbow, but no further. And then after a session of the pneumatic compression therapy with the FlexiTouch, you see that the limb has more of this icy green, laden extravascular, but moving from distal to proximal. We see that in all of our cases, where before we don't have an awful lot of coverage of that icy green lymph, and we see that after the treatment, it's always moved. In this last case, you see that after an injection near the wrist, there's no dye, but after the treatment, you see that dye is moved proximally to those draining lymph nodes. The idea of moving that fluid and getting it away from, moving it towards a functional lymph draining bed is the basis of these technologies and the basis of MLD therapy. So what I've talked to you about is how we've used this technology for looking at secondary primary lymphedema and the treatment thereof. And this is a costly disorder, but I want to point out that most of our chronic conditions actually involve defective lymphatics. And what I'd like to do is talk about chronic wounds and peripheral vascular disease. And in venous disorders, it's always thought that whenever there's venous hypertension, the edema that's been formed is really due to this hypertension, and that effective treatment is to basically reduce that hypertension so that you reduce the edema formation. Well, we don't really have edema formation if the lymphatics are functional. So if the lymphatics are not compliant and don't respond to that excess fluid, we have edema formation. But in addition, those same symptoms of swelling could be due not to venous hypertension, but also just due to the fact that the lymphatics themselves aren't working. So whenever one has edema in the lower extremities, one could have it because you have venous disorders, you have lymphatic insufficiency, or you have a combination of both. And this is some of the cases that we've actually seen, where whenever a patient presents with a swollen leg, you have to ask, is it a venous disease? Is it a lymphatic disease? Or is it a combined venous lymphatic disease? This is the case of an adolescent girl who in puberty ended up with a swollen leg. And she was treated with stenting, venous stenting, because there was venous hypertension and there seemed to be venous compression. So once a stent was placed, it's expected that the venous hypertension would be resolved and the swelling would resolve. It did not. And upon imaging, what we see is her affected leg has dermal backflow. Clearly, the lymphatics are involved. This is all compared to her normal leg, which has dilated lymphatic vessels, but clearly not the dermal backflow that we see in the contralateral leg. Interestingly, when we look at the ankle, we can actually see that dermal backflow, but we see deep in that ankle, we see that functional lymphatic vessel pumping. So there's hope that we can basically get those lymphatic angions working again so that we can create the sufficient pressures that move lymph distal to proximal and get rid of that dermal backflow. So this is a case where it was not just a venous disease. It could have been a purely lymphatic disease or a combination of a venous lymphatic disease. But yet you still have to understand what the relative contribution for the lymphatics are to this edema. This is an interesting case where a subject presented with Klippel-Trenaunay syndrome, a venous disorder. And before the clinician was going to treat and ablate the veins, he wanted to see if there was a lymphatic abnormality. And what you see here is the lymphatic pumping that's occurring as this subject is actually standing. And you see in his normal legs, you get this wonderful pumping, lots of vessels, and compare that to the vessels that are in his affected leg. You see the port wine stain, and you see those lymphatic vessels that are pumping, but they're not as many. Again, this swelling occurs because of a venous condition, but the lymphatics are insufficient to take up that excess fluid. So here again, even though we don't have dermal backflow, those lymphatics need a little bit of an assist. In patients with venous insufficiency and venous wounds, the images are, we don't have to show any movies because there's really not a lot of motion. We see that they have lymphatic vessels, but they seem to have this lymphatic pooling or dermal backflow at the sites where their vascular wounds are, or where the vascular wounds will appear. So it suggests to us that these lymphatic disorders, or these venous disorders, inherently involve the lymphatics. Indeed, when you go to the classic textbooks of peripheral vascular disease, whether it's arterial disease or venous disease, these diseases are called the inflammation of the blood vessels. And so you would think that if there's inflammation and the lymphatics are supposed to remove these immune cells and the inflammation, if those aren't working, then your blood vessels become inflamed. And that's what we see. This is a picture of a person with venous insufficiency. He's an early stage, no vascular wound, an injection at the ankle, and you see there's dermal backflow. Not what you see in normal subjects, the healthy subjects without venous disease. Here's a subject that has a mixed arterial disease, mixed arterial venous ulcer, pretty young ulcer. And what's interesting in this patient is that you don't see symmetrical lymphatics, which is what you normally would see. You see a lot of dermal backflow around the vascular wound. On the contralateral leg, which is healthy, you see this dermal backflow in the same regions. Perhaps there's going to be an ulcer that forms there. Don't know. We know that in early ulcers, the immune system is really revved up, and the lymphatics are supposed to take away that dying material, the immune cells, take away the waste products. And what we see here is we see an awful lot of lymphatics compared to the healthy contralateral leg. And we know that the lymphatics are really plastic because they basically change, they're recruited in order to remove these immune cells and waste products from this area, in which case is an ulcer. If we blow up this area of this lymphatic, these plastic lymphatics that are working very hard, and I'm going to show this moving. You know that lymph is supposed to move distal to proximal. And I want you to watch very carefully this movie. And remember, the lymph is supposed to move from the bottom of the screen to the top of the screen. When I move that, watch this. Did you see that? It moves downwards. It's almost like there's a lymphatic reflux. Like there's a venous reflux, there's a lymphatic reflux. And we think this is occurring because this inflamed site of this ulcer basically is spewing a lot of cytokines. And our work with animals shows that whenever there's these pro-inflammatory cytokines, such as TNF-alpha, IL-6, IL-1 beta, when these go up, in our mouse models, what we find is that there's reflux. This is a mouse on the side. Mice don't have as many lymphatics as humans do. This is the inguinal lymph node. And they have a single lymphatic vessel that propels lymph from the inguinal lymph node to the axillary lymph node. It's supposed to go distal to proximal, right? So when we give this mouse, we administer these pro-inflammatory cytokines, what you see is some of the same behavior. We see lymph going backwards. Did you see that? So we think what's happening is that there's this inflamed state. The lymphatic vessels are dilating in response. The valves aren't working. The pump is weakened. And so we're not moving lymph effectively. And as a result, those immune cells and all those cytokines are building up and perhaps may be responsible for the formation of the ulcer in the first place. We've used the flexi-touch therapy to actually try to move this toxic lymph away from the wound site. And these are some of the images of patients with active wounds where we're actually moving that lymph away from the wound after this flexi-touch treatment. So the idea of moving the metabolic waste products, the dead cells, and these cytokines out of the area gives the wounds and those ulcers a chance to heal. So what's interesting about this is that for the first time, I think we're looking at longitudinal changes and that we can actually ameliorate this dermal backflow that we have used in the past to characterize the initial onset of lymphedema. And so perhaps now we're able to manipulate the lymphatics so that we can relieve the symptoms associated with these very chronic conditions. You know, before there was blood vascular imaging, angiography, we didn't have a lot of treatments for the blood vasculature. Now we're imaging the lymphatics routinely. So now you might imagine, now we might be able to come up with some cures for not only the chronic conditions that I discussed, but several other chronic conditions. Thank you for your time and your interest in the lymphatics.
On behalf of Tactile Medical, Dr. Sevick, thank you so much for sharing your passion and your research. And attendees across the country, thank you for taking the time to tune in and join us. At this time, as we don't have questions on the phone, we'd like to go to some of the questions that have come in through the webinar portal, Q&A. So first, Dr. Sevick, can you please explain further why ICG isn't available as a clinical diagnostic tool in the U.S. today?
Well, ICG is approved for an IV administration for looking at liver function, vascular abnormalities, and looking at skin perfusion, or not skin perfusion, but perfusion in surgical procedures. It's not approved for the intradermal administration, so that's why it's an off-label administration. So hopefully we're going to be launching the lymphatic imaging system for ICG administration shortly once we get the FDA clearance for market approval. So ICG is off-label right now. It's used off-label, but once it's approved for the market, then it should become available in the United States.
All right, thank you. And another question from the webinar portal. You mentioned lymphangien pulse rates differing from one subject to the next. Has there been any research on correlation of lymphangien pumping rate to activity levels and exercise? And then the same question for BMI.
Anecdotally, we've done about 500 patients on the Texas Medical Center and in the surrounding Houston area. And every now and then we get an athlete that enrolls into our studies. And anecdotally, I can tell you that those athletes always have incredible lymphatic pumping. They have lots of lymph vessels and they pump. We believe that, you know, cardiovascular health is synonymous to lymphovascular health. So although we don't have the studies, a specific study to prove it, it's an observation that we've made. Once we get these devices in other people's hands, it would be interesting to see if others can make that association in terms of activity and lymphatic function. As far as BMI goes, we expected to see that as the BMI increases, the lymphatic pumping would decrease. That was our expectations, and I think a lot of people think that would expect that, because obesity is often also associated with systemic inflammation, and we know that inflammation arrests the lymphatic pump. We did a retrospective study with some summer interns a year ago and 2 years back, and we asked them to look at all the images and see if that they could find this correlation between BMI and lymphatic pump rate. And it was really interesting is that correlation did not exist. We did not find a correlation. We did not find the expected correlation that with increasing BMI, the lymph pumping function decreases, which was a little bit surprising to us. It may very well be that the lymphatic pumping function is more directly correlated to inflammatory states, and BMI and inflammation is probably a looser correlation. Perhaps that's the reason why. More research needs to be done in this area to fully answer that question.
All right, thank you. And now going back to the webinar portal, we have a question that came in from Stephanie Amati at Lymphatic Therapy. Thank you, Stephanie, for identifying yourself on this. The question is, I was wondering if you're able to locate or see the damaged, blocked lymph node or the area with NIRFLI imaging.
So remember that when we put an administration of the indocyanine grain intradermally, it's taken up, and it's taken up by functional lymphatics, okay? So we only see functional lymphatics. That's kind of an interesting aspect, because you have to have some function in order to draw that indocyanine green into the lymphatic vessels. Now, when there is a damage upstream of a watershed, what we'll see is we'll see uptake near the injection site, and it'll go so far, and then we'll start to see that dermal backflow coming back. And so, or we might see lymphatic rerouting is another thing that we see. And so that's where you infer that there is a blockage at that point. So right now, the lymphatics are really depend upon a contrast agent for medical imaging, and these lymphatic vessels won't take up that contrast agent unless they're functional. That was a really good question.
All right, thank you, Stephanie. And so, Dr. Sevick, another question from the webinar portal. Have your imaging studies shown any difference in lymph flow rates or patterns between primary lymphedema and secondary lymphedema?
At this point, we don't believe so. I think as you understand that, primary lymphedema is relatively rare, so it may very well be that as we secure more patients with primary lymphedema, some correlation might pop out. But at this point, our imaging just says, look, you've got defective lymphatics. It doesn't really ascertain the cause, and I guess you get that. You come from medical history to infer what the cause might be. However, we've had several study subjects over the years that have come in with lymphedema with no apparent causation, and suggesting that there might be familial or inherited or a primary lymphedema. And one of the things that we do often look to see in those cases is if there's a lymphatic abnormality not only in the affected leg, but perhaps in the unaffected leg or unaffected limbs. And usually when we see any abnormalities in the quote-unquote unaffected limbs, that's kind of a clue that we have primary. We suspect primary even more strongly. But there really isn't a way to ascertain what the cause is of that lymphatic dysfunction. So more research needs to be done in this area. If we have used the lymphatic imaging to actually phenotype and find genotypes, and we found a couple new gene variants that are that causes lymphedema. We've taken family members who are asymptomatic but carry a gene mutation or a gene variant, and when we image them, they have abnormal lymphatics. And so with the imaging, we've been able to actually to identify new gene variants that are associated with lymphedema. And some of those have been published and now are being validated by other genetics laboratories around the world.
Well, thank you very much for that answer. It's really definitely an interesting and emerging subject as we learn more about genetics and some of the speculation that even primary is more common than we ever appreciated. Another question that came in through the online portal, Dr. Sevick, have you been able to see any distinguishing patterns in lipedema as compared to lymphedema in your imaging studies?
Yes, as you may know, lymphedema appears in very late stages lipedema. And in lymphedema, we see that dermal backflow. But in early stages of lipedema, we actually see more dilated lymphatic vessels. And in the very early stages, it appears to us that we have a lot of lymphatic pumping. And that makes sense because if you have an inflammation, then the lymphatics pump, and then they wear out and then they become dilated and pump less. So this is research that we're conducting with the Lymphedema Foundation, and we're still in the process of doing that. But when we don't typically see dermal backflow, we see lymphatic straight vessels, and we see pumping. We tend to see that they appear to be dilated. And again, in early stages, we'll see more pumping, and in late stages, it appears that it slows. And then when lymphedema sets in, we'll see that dermal backflow. I hope that answered the question.
Thank you. So at this time, we do not have any additional questions through the online portal, and there are no more questions on the phone from what we can see. So again, Dr. Sevick, thank you so much on behalf of Tactile Medical for sharing your passion and your research and expertise with us all. And thank you to those sites across the country that took the time to join us today on the webinar. For those of you who do have questions that come up afterward in discussion, please submit those to your Tactile product specialist, as we'd like to collect those and then be able to follow up through email with Dr. Sevick. So thank you again.